Good morning, everyone. I'm Callie Palmer, Chief Executive at the Royal Marsden. It's a specialist cancer centre in London. And I'd just like to introduce Dr. Shelley Dolan, who's a cancer nurse and happens to be Chief Nurse at the Royal Marsden. Dr. Tony Brzezinski, who is a GP and chairman of one of the largest CCGs in London and also cancer lead for a London programme to transform cancer. And Miles Scott, who is my colleague and Chief Executive at St George's Healthcare NHS Foundation Trust. I'm just going to do a very brief introduction, if I may, and then hand to Shelley to talk about the detail of our proposal. And a bit like the Christie, I'd like to start with the problem we're trying to address, or the issue we're trying to address for patients. We know in London and elsewhere in the country that cancer care is variable, fragmented. Patients find it slow to get to a definitive diagnosis and treatment. And we want to put a model in place that allows us to get patients the right treatment in the right place first time, not second, third or fourth time. Our proposal is an accountable clinical network for cancer in West London initially. It covers a population of 3.2 million, covers about 2,000 cancer clinicians already working extremely closely together on pathways, again like the Christie's model. It covers 10 trusts, 13 clinical commissioning groups, hospices and key organisations. What's different? I think there are three things about what's different. It's a collaborative model, so it is working across the whole system. Completely different levers and incentives. We want this to be a proper accountable network with a funding mechanism behind it, so it's bold. And it does cover the whole pathway from primary and community care through acute care to end-of-life care. So it's very different, and the reason we need the vanguard is to give us, it's a bold initiative requiring this kind of political and technical support. So Shelley, over to Shelley now on the detail.
Thank you. So the Accountable Clinical Network for Cancer is bold and ambitious, but we have good plans, fantastic collaboration, and I'm just going to talk through very briefly 6 key things. At the centre is the patient and family voice. We have worked for some time with Neil Bacon, the Chief Executive of I Want Great Care. And right at the centre of our model, patients and families in real time using smart technology will be evaluating our ACNC and setting key performance metrics right from the word go. So patients truly are at the heart of the model. It will also reduce variation and fragmentation because for the first time, all of the partners in cancer, looking at the whole patient journey from prevention, early diagnosis, survivorship and end-of-life care, are bound up in one organisation, accountable together with the lead provider, which is the Royal Marsden. We are working with public health and primary care on exciting research for early detection of cancer and, of course, prevention. We've already written, over the last 2 years, evidence-based exemplar timed pathways for cancer care. Over 3,000 clinicians have contributed to those across London, and we will use those to drive better care. And also to get people into greater numbers of people into international clinical trials. Very important to change survival. So first tranche of KPIs is around patient experience. Second is around survival and better care. This is not a vanguard about making 1 or 2% difference. This is about 10 to 15% difference in survival. We work with the National Data Registry, so we know the figures. So we have about 20,000 new cases of cancer treated in this area of London, and we hope to see survival change in 350 to 400 cases. The other big difference Callie alluded to was the funding. All the partners in this model have agreed, if we get this, and if there's the political will to allow it to happen, to put all the cancer funding in this model. Money is an important lever. We've done a lot in improvement architecture, as the questioner just said, but now we really need to make it happen for patients and families. And there's good evidence from the United States that the money is important. But what we're not asking for is more money for cancer care in London, not for the ACNC, not for the Royal Marsden. The US has shown that with these models, the utility goes up and the costs come down. So we will save money and be more productive and efficient. There'll also be improved clinical safety. We will, right from the get-go, share all SIs, all complaints across the whole system so that we can use the system effectively and learn in real time. Also, we'll ensure that this is 24/7. So this will mean that patients and families at 2 o'clock in the morning at the weekend will not be ringing 999 as the services are not linked up. Right from the beginning, and this is my last point, we will be modelling this model with the experts in the Cumberland Initiative who have worked internationally to model new healthcare settings. And this will ensure that our system is robustly and objectively monitored and evaluated and can be used by the vanguards across the NHS to our colleagues in Manchester and our colleagues at UCLH in London. We have already established benchmarks with our colleagues internationally, and our colleagues in the US who have done a lot around these models have never done anything on patient experience. So they're very keen to learn from England on that. And we're keen to learn with others, with the Christie and UCLH, who you'll hear from at the moment. Above all, everything will be transparent to patients and families, to commissioners and the NHS. So in conclusion, yes, the Accountable Clinical Network for Cancer in West London is a very bold initiative. But actually, people really deserve a step change in their cancer services. The Royal Marsden has an international track record for delivering excellence in cancer care research and education. And with our fantastic partners across the system in West London, as one of our CCG chairs said to me last week, this will be a game changer for cancer and the NHS. Thank you.
Thank you very much. It was perfect timing, 7 minutes on the dot. Thank you. Any questions for the team from the Royal Marsden Hospitals? Colleague over here.
I'm Steve Sharple. Can you tell me, please, you talked about smart systems. Can you explain those more?
Yes, for the patient experience. Yes, so we've been working with Neil Bacon and I Want Great Care, and we will have the same system throughout hospices, GP surgeries, the community providers and hospitals to measure real-time patient feedback. And the work we've been doing is using smartphones. We did a pilot with some colleagues in Glasgow looking at the older person and measuring their CSA scale, a chemotherapy scale. And actually, we found that all parts of the community are very well used to using smart technology. So it doesn't extend everywhere, but we can use different technology for different people. But actually, the international work led in Scotland showed that actually there was great use of technology by all parts of the community. I hope that's helpful. Oh, sorry.
Thank you. Ian, please.
Ian Dodge, NHS England. Great presentation. 2 questions. In February, the team presented a slightly different proposal around rolling out your specialty franchise model, building on the chemo and radio that you've been successfully delivering in Kingston and other places. Could you just explain how what you're now proposing builds on and goes further than that? That's the first question. Second question is particularly to Miles. So you said in the presentation that this is kind of hard-edged, real, accountable clinical network. So what will this mean for surgery at St George's?
Okay. Well, I'll start, if I may, on the franchise model, and then it's more appropriate for Miles to talk about his institution. So our earlier concept was a franchise model, so RMH at. We looked at that very carefully, and the problem is we need something that's nationally reproducible and that's fast and collaborative. And RMH at is something we can do anyway, but it's slow because it often requires capital investment, and it's the Marsden doing too. What it isn't is a collaborative partnership where we're all taking risks together to make it better for patients. So I think the concept behind this culturally is really important because we're all going to be taking a risk with our cancer business. Miles is, I am, we all are. So the 10 trusts, the 13 CCGs, to get to a completely new model. And it'll be nerve-wracking, but then that's what Vanguard's supposed to be about. So, Miles, on surgery at George's.
Yeah, sure. So I think this is a really important question, and I think this is exactly where this Vanguard proposal will do stuff that we can't do at the moment. So we have lots of established alliance working, but it's based on the principle of a coalition of the willing, if you like, and we've achieved a great deal, particularly in areas of patient experience, but it's all been done based on everybody, on consensus, essentially. What this model will enable us to do is by establishing a joint delivery vehicle with a clear structure and clear governance and rules of engagement, the organisations who have, frankly, a large commercial risk, a large service delivery risk, are saying we are prepared to put our cancer services together into a joint delivery vehicle because we understand how we will be able to reshape the services that we provide without either disadvantaging the rest of our organisation, undermining the rest of our organisation, or undermining services that are outside of cancer. And that's the big distinction between, I think, this and the RMH Act franchising model, that we can go beyond chemotherapy and radiotherapy. We can get into what are probably the more difficult areas, actually, of joint working around surgery, around gastroenterology, and so on, because we've worked out, we believe, how to retain people's interests, both clinical and, frankly, financial, and yet deliver the standards that we aspire to at the same time and make real change in that.
Thank you very much. We've got time for one very quick question. The woman in the back, in the red, please.
Really good proposal, obviously very big project that you're proposing. Just wondered, what's the thing that keeps you awake at night about it? What's going to be the biggest challenge in moving this forward?
Thanks very much. Tony, do you want to address that as a key cancer leading commissioner?
So there are two tickets in town, bearing where we are in cancer. One is early diagnosis, and working across the secondary and tertiary care system alone does nothing at all to alleviate that. So working with primary care, the community, Public Health England around early diagnosis is absolutely crucial. So you can improve early diagnosis, and there's a lot in the commissioning intentions, but we have 13 CCGs, so you do the same piece of work with 10 providers, 10 providers, 13 CCGs in a matrix model, or you do it all together and implement it quickly and effectively, and that's where the survival benefits Shelley spoke about comes from. And the second is variability in care, which can, in the short term at least, can have approximately the same benefit for patients. So North West and South West London already have established protocols. They already have the data understanding where the variability is, but they haven't a governance model to push through and enforce changes to improve care and level it up across the organisation to international best standards. So that is the fundamental difference to what's been going on before, and that's why for us in West London this is a critical vanguard.
Thank you very much. Thank you very much to the Royal Marsden team and partners. Please give them a big round of applause.